Hello, everyone. So I think we can definitely start. Thank you for joining our webinar. My name is Ofer Forer. I'm the head of the Israeli Economic and Trade Mission at the Israeli Embassy in the UK. And it is my pleasure to host our seminar today, which will provide practical overview of the NHS structure, existing procurement channels, and will also introduce the NHS supply chain and provide information about available programs and support from the Innovation Agency of Northwest Coast AHSN and the Department of International Trade at the UK government. Our webinar today is kind of a different webinar than one we had before, because we're not going to talk on NHS on the macro level, but also from the micro level, specifically how an Israeli startup, an Israeli company can enter the procurement processes and how to do the health economics, which is specifically relevant for the UK. Before we start, it is my pleasure to invite Asaf Barnea, the chairman of the Healthcare Life Science Advisory Board at the Israeli Export Institute, to give his congratulatory speech. Asaf, our podium is yours. Please unmute yourself.
Thank you, Ofer, and a pleasure to meet you. I'm very happy just to say a few notes, since the UK is definitely a very important market for us. I think under the COVID-19, we all have seen and experienced the need not just to keep on collaboration, to do the collaboration that we used to do. And one of the things that within the Export Institute, we put the phrase of business continuity, while the COVID-19 was striking last year and this year. And actually, I think the right expression should be business acceleration of whatever we were doing and whatever we should be doing together. Everything that has to do with knowledge sharing, everything that has to do with technology collaboration, and truly dive into a deeper stage of relationship. On our side, definitely from the Export Institute, on behalf of the Israeli government, we are trying to increase almost $9 billion of export out of Israel. This is including all the life science related components, which is biotech, pharma, medical devices, digital health. And now a new up and coming area for the state of Israel is what is being defined as the most disruptive technology in healthcare, which is bioconvergence. This is biology being engineered with material science, with tech, with software, with physics, or any other multidisciplinary approach. So those would be bioconvergence, definitely digital health, and the old fashioned biotech and medical devices that we developed quite significantly in Israel. We would be more than happy and definitely supportive of anything that should be done to increase and take it to the next level of collaboration with the NHS, with the UK market, and hopefully that could lead us to a lot of other collaborations, which in some areas the UK may be a bridge to some other designated countries. So with that, I'd like to end, wish everybody success, and hopefully taking it to the next step following as a follow-up with that conference and the follow-up meeting that will result from that. Thank you much.
Thank you very much, Asaf. And as you mentioned, talking about the next step, when it comes to the next steps in the Israel Economic Mission to the UK, our strategic partner is the Israel Export Institute. And in that case, it is my pleasure to invite Alona Trivax, Business Development Manager of the Life Science Department at the Israel Export Institute, to share what they are planning to do when it comes to the UK and in general. Alona, our podium is yours.
So, hello everyone. Thank you, Ofer and Ivana, for including us in what I'm sure will be a very meaningful and insightful webinar. And thank you very much for our distinguished guests and speakers. Please excuse me if I'm mispronouncing your names. Dr. Linda McGee, Dr. Armando Vargas Palacio, Chris Slaughter, Colleen Clough, and Asaf Barnea. I would like to share a really quick brief about the Israel Export Institute. This is short IEI. It's a non-profit organization supported by the government of Israel and the private sector to advance the integration of Israeli tech into the global market by providing a wide range of export-oriented services. At the Medical Device and Digital Health Unit at IEI, we represent almost 70% of the life science industry, and we are engaged with more than 800 companies on a yearly basis. We have a variety of ways to support it. We are organizing one-on-one meetings, roadshows, now virtual, but hopefully will be on ground soon, seminars, and last but not least, establishing the Israeli national pavilions and the leading international trade shows such as HIMSS and Medica. It's done mostly with Israel trade missions around the globe, such in this webinar. Only in last June, we partnered with the Israeli trade mission to the UK on a large virtual B2B event, setting up meetings between more than 40 Israeli companies who showcase the most cutting-edge technologies that the Israeli medical industry has to offer to the UK market, in front of 10 NHS hospitals. In a total, more than 70 meetings were held in a short time of 2 weeks, and we're already seeing significant results. Today's webinar seems the natural follow-up event, of course. Thank you.
Thank you very much, Alona. And as you mentioned, the project that we've had was a very close one, which allowed us to really work closely with the NHS. And talking about working closely, I would like to invite Ivana Kiselkova, a trade officer in charge of healthcare at the Israel Economic Commission to the UK, to share a bit about what we are doing and how Israeli companies can engage with us. So Ivana, please.
Thank you, Ofer. So good morning. My name is Ivana Kiselkova, and I'm a trade officer at responsible for the healthcare sector in our team. Basically, similarly as other missions around the world, our purpose is to support Israeli companies such as yourself with internationalization. In our case, it's the UK. And apart from organizing different industry relevant events similar to this one, we can provide you with information about the UK healthcare industry, its specific and the local regulatory environment, help you find business partners in the UK, connect you with relevant healthcare organizations and investors, as well as advise you on possible market entry strategies. So we are here for you. Thus, if you are considering the UK as your next export destination, do not hesitate to reach out to us. I will leave my email address in the chat box below. I thank you and enjoy the seminar.
Thank you very much, Ivana. So following up to the main event, what we are planning to do is to start over with an overview of the NHS to provide you, the Israeli companies and guests, an overview of the NHS structure, the partnership and the processes. And in that case, it's a great privilege for me to invite Dr. Linda McGee, a health innovation and NHS specialist at the Department of International Trade at the UK government, to present her presentation. May I just mention that this webinar is recorded, and should you have any questions, we're going to have a dedicated Q&A session, but you're also able to ask your question or give your remarks in the Q&A box on the bottom part of the Zoom room. So Linda, I leave the floor to you.
Thank you, Ofer, for that kind introduction, and hello to everyone, the audience today. Thank you very much to Israel's Economic and Trade Mission for inviting me. So I'm now going to attempt to share my screen and get my presentation up. Hopefully, let me see. Can you see that, Ofer? Is the first slide?
Very clearly.
Good, thank you. Well, I've got a short time. I'm going to give a very quick overview, and hopefully I will set the scene for some very expert speakers who will follow. And I would just like to echo something of what's been said earlier. We're very keen to work with you in partnership to look at this Israel-UK opportunities in this area. So I've started off with a company checklist, and all of you will know these things. I'm not telling you anything you don't know, but I hope giving an overview and through the speakers that you're going to hear from today, we can show how we can help you answer these questions. Obviously, you've got to meet the regulatory requirements, and I would stress the data governance requirements for digital products. How does your product fit into the care pathway? clinical support, meeting ways of life. And I think very importantly, you're going to hear more about this, having a strong and relevant evidence base for efficacy and effectiveness. How does your product or process work within the context of the NHS? So let's have a look at what the NHS is about, how it's structured, and how the UK Health Innovation System can support you to answer these questions. As Offer said, all of these slides will be available. I know there's lots of information, so don't worry about taking lots of notes. So the UK is a prime location for not only identifying innovation, but you do a great deal of that in Israel, but to research, develop and evaluate products and services. The National Health Service is serving nearly 67 million people, and it's one of the world's best healthcare systems and one of the largest public single-payer systems. So it is a test bed for global market development. We've got lots of dedicated infrastructure to support R&D. We've got national agencies working ever more closely together to improve our innovation pipeline and the adoption process for streamlined market entry. We've got a very significant commercial sector here with connected clusters across the UK. And you're going to hear more about those from Colin and Elaine later in the agenda. And then we've got government commitment to innovation. And this has been underpinned by sustained partnership with industry over many years now through sector deals and a new life sciences vision. And that's already realised more than 3 billion in joint investment. So on to the National Health Service. What does it look like? Well, it's actually 4 sister organisations across the UK. We've got NHS in Northern Ireland, we've got the NHS in Wales, the NHS in Scotland, and the NHS in England. And all of them can be very valuable places in which to partner and work. But I'm going to focus particularly now on NHS England, which, as you can see, is representing 85% or thereabouts of the actual population. It's also worth stressing that it is a public payer system, as I think many of you are aware, and it represents about 80% of the UK's healthcare market. So by far and away, the major part of the healthcare market. So who does what? Well, the Department of Health and Social Care, one of our government departments, funds the healthcare system via taxes agreed by Parliament. And the majority of these funds do go down toward NHS England, plus core departments costs, the agencies, units and arm's length bodies. NHS England, which now with NHS improvement is really one body, funds commissioning, specialised services, so that, for example, might be blood and transplant services or NHS Digital, and our general practitioners. The healthcare system is regulated by the Care Quality Commission and supported in its quality with NHS improvement. But healthcare products are regulated by the Medicines and Healthcare Products Regulatory Agency. NHS Commissioning is carried out the process of planning and agreeing and monitoring health services for a population, and it does occur at national level, but mostly at local level with our local commissioning groups or CCGs. Moving now to more integrated systems with our local authorities who are responsible for social care. Our providers deliver the commission services, typically the NHS hospital trusts, as well as primary care and GPs. And the general practitioners are the gateway to the NHS for the patient, other than things like accident, emergency, and we do have some walk-in and specialist clinics. So what are the NHS's priorities? In 2019, there was the publication of the NHS long-term plan. And this set out really the vision for the next 5 or so years. Quality of care, reducing inequalities, improving efficiency, keeping people out of hospital. We only want people in hospitals where they can receive the treatment they need, and we don't want people to have to be in hospital when they don't need to be. Mental health is equally important as physical health. There's a great deal of focus on this now. Prevention, early diagnosis, and improved management of long-term conditions. And with that has come a huge burst of activity in genomic sequencing, for example, and the direct translation through of research in genomics through to clinical support, and improving the patient experience through the care pathway. And of course, now we also have the challenges, as we all do, of responding to the COVID pandemic. Not only what we're doing now with COVID, but how we deal now with elective processes that have been halted in some cases because of COVID. Now, this is quite a complicated slide and there's a lot on it, but it's really to highlight the huge breadth of innovation support that there is out there. And again, you're going to hear a lot more about this later on. So we've got Innovate UK, part of UK's research and innovation, which is really funding both our academic colleagues, universities, but Innovate UK, for companies that are in the UK, there are grants directly to small and medium enterprises for R&D processes. We have a series of catapults, which can provide services in key areas. In life sciences, we have one, for example, in cell and gene therapy. We have one in discovering medicines discovery, which also includes and leads out to some diagnostic activity. And we have things in like advanced engineering. HDR UK has got the health data research hubs. So they're looking very much at the application of data to develop therapies, treatments, and improve health. And they're working across clinical and general areas. Then there's the whole National Institute of Health Research Infrastructure. And you can see there's a lot there, including our clinical research networks, which directly support patient recruitment in clinical studies. Down at the bottom there, not part of NIHR as such, but linked very closely with that infrastructure in areas are the academic health science networks. And Colin's going to tell you a lot more about those later on. The NHS is also, of course, the payer as well as the host for many of these activities. We've got MHRA, the regulatory agency as mentioned, NICE, and then we've got the Accelerated Access Collaborative. Now, you probably can't see all those logos, but that's really all about bringing all the key organisations together who can support the uptake and adoption of the best innovations of value to the population. And just at the bottom there, very recently published our Life Sciences Vision, and you can see the areas of focus there, including 7 great healthcare missions, which we're all aware of. And these are the areas where there's going to be particular support for R&D, for example, in these areas in the UK. So market access, just to come back to MHRA and NICE, this is the regulatory agency. It's now the UK standalone medicines and medical devices regulator. We have an innovation office, which is open to ideas. You can contact them and they will help you from the earliest point. And for those in the audience who are developing new medicines, for example, we have the Innovative Licensing and Access Pathway just launched at the beginning of this year. And that's really working hand in hand with innovators even from the preclinical stage to work through what the pathway to adoption would be and give the best possible advice. And we are told there will be something similar coming on board for medical technology. NICE, National Institute for Health and Care Excellence, is important because they actually, in simple terms, look at value for money for the NHS. So they will evaluate whether technologies represent good value. They don't look at all medtech, they look at all new drugs. But recently launched is the MedTech Mandate, which is a policy around a much more defined reimbursement process for devices, diagnostics, and digital products. Market access. Well, this is what you're going to hear more about. We have in DIT got a couple of information sheets, which please contact us for them if you would like. One is a little bit more information around the checklist and the key organisations that can help you. Another one tells you a little bit more about the actual supply chain, the contacts for getting on to product frameworks and so forth. So this is more information for you also on the slide. And it's worth emphasising, the NHS wants products and services that are innovative, beneficial, well evidenced, and save money. And of course, it can help companies to actually develop, test, and evaluate those products and services. So just to finish off, I'm not going to go through this in detail. And again, Elaine's going to say a little bit more about how we can help you in DIT. But these are some of the things we can do if you're interested in coming over to see us and partner with us and working with our organisations. And particularly, of course, we're focused now on how we can help you access the NHS. Thank you very much, Ofer.
Linda, thank you very much for making a very complicated issue very simplified. I think such a presentation could last for 2 days at least, and but I do believe, at least from my point of view, that you really gave the right, I would say, framework for the rest of this seminar and webinar. So thank you very much.
Thank you. I'm sorry I had to cover so much in so little time, but we can always come back to it in questions. Thank you.
Yes, thank you. So as Linda mentioned, we will have a Q&A session, and this webinar is recorded, so it will allow you to go over the presentation once again, should you want to do so. And as Linda gave, I would say, the framework for the webinar, I would like to take it one step further to talk about healthcare economics. In the case of us, Ivana and myself here in the UK, when we work with Israeli companies, we notice many of them, when they are tapping into the UK market, they are based their healthcare economics on the US model. And not many Israelis understand the UK model. And this is why I'm very pleased to have the opportunity of having Dr. Armando Vargas Palacio, who is a senior research fellow at the Leeds Institute of Health Science at the Leeds University School of Medicine, who will provide us tips and guidance. How does the healthcare economic works here in the UK? So Armando, the floor is yours.
Thank you. Yes, thank you. So I'm a research fellow, senior research fellow in the academic unit of health economics. And I mainly work on economic evaluations of different technologies, medtech, medical devices for in the context of the NHS. So today I'm gonna talk a little bit about what we do in health economics, how it's embedded in the NHS, and what can we offer, or how can we help in terms of health economics if you're looking for that for your products or devices. So I'm going to share my screen. Hopefully you can see. Can you see my presentation?
Yes, I can.
So basically, I'm going to talk about what's health economics, what's needed, and how can we help. I'm happy to answer any questions after, I think. And obviously, you can contact me if there's any more need, or if you want to discuss further some of these aspects or some of these considerations. So just to give a bit of a context. So as Linda was mentioning, Nhs is a national institute for health and care excellence, which is in charge of ensuring that everything that is offered in the NHS is good value for money. So since its creation, really, it has a focus on evaluating the clinical effectiveness. They don't really evaluate it, they assess with the information provided by the developers or pharmaceutical companies, the clinical effectiveness, and what is the topic of interest for my presentation is the cost effectiveness or economic evaluation of the interventions or the devices, drugs, medications, etc. Because the idea is that everything that is provided in the NHS represents a good use of public resources. So one of the things they do, they have many functions, but one is a technology appraisal. So they make recommendations on when and how new and existing medicines and treatments should be used in the NHS. And as part of this, they use economic evaluations to make their decisions or to make their recommendations in order to see if a medical device or a new drug should be implemented, should be used as standard of care in the NHS. Obviously, they have a variety of issues when they discuss if a medication should be implemented, and one of them is its cost effectiveness compared to what is already being used in the NHS. So here is what health economics comes from, because health economics is a branch of economics, but is specifically related to choices in health and healthcare. So its main aim is to provide robust information to aid informing choices. And the idea is to ensure that the benefits of a program, medication, new intervention, medical device, exceed the implementation of these, exceed their opportunity costs. So they offer more than what they take off by providing it. So it's a structured approach to help decision makers to choose between alternative ways of using different resources. So pretty much what economic evaluation is, and the aim is a comparative analysis of alternative choices. And that's a key thing. It's a comparative analysis between cost and consequences. It's not only about using a medical device or a medication will save so much money to the NHS. It's also about how much it offers for the patient. So it's a combination of both costs and consequences between two or more alternative treatments. So we create this analysis also as health economists, comparing two or more interventions in terms of how much they cost, how much they provide to the patients. It could be also, we have to take into consideration potential, for example, side effects, etc. So we cost all of that. We evaluate all of this, the potential outcomes in terms of quality of life, to estimate what we call a cost effectiveness ratio, an incremental cost effectiveness ratio, which is just pretty much a difference between how much it costs versus comparing how much it costs the new intervention versus the standard of care and how much effects it provides. And NICE uses this cost effectiveness ratio to determine the cost per quality of life gained. And if the new intervention provides what we call a cost per quality gain, which is below a £20,000 per quality gain, then the intervention is considered to be good use of public resources, and it should be implemented or should be recommended for use. So this is pretty much the guidelines. So the NICE guidelines of 2013. So cost effectiveness of a technology is not the only thing, as I mentioned, considered in the decision or in the recommendation of NICE to implement it, but it's a big part of it. So if the cost per quality of the intervention is below £20,000 per quality gain, is likely to be recommended. They have a higher threshold of £30,000 where they have to consider other factors, other considerations to see if they're recommended or not. But if the cost per quality is higher than £30,000, it's unlikely to be recommended, unless there's a strong case made for it. This threshold sometimes can be bigger for end-of-life care treatments or cancer, for example, cancer treatments, cancer drugs who are much more expensive. Okay, so the HTAs or the appraisals are strong, especially when we are talking about medication and medicines, because if NICE recommends its use based on cost effectiveness and other things, NHS is legally obliged to fund those resources for the patients, so they have to provide them. However, this is not the same for medical devices, or not at the moment. So for medical devices, it's just an advisory, it's a recommendation for implementation or for use. It means that NHS is not obliged to provide it or to use it, although NICE might recommend this is a cost-effective strategy and we recommend it for this and this and these groups. This doesn't mean, I think this is on the review, and it might be subject to change, and might be more likely to be similar to what is in medications. Another thing that is important for medical devices is not only just cost effectiveness in terms of cost per quality, it also has to be cost saving. It means that it has to show that it's of a benefit in terms of cost, not only on quality of life. Okay, but apart from that being an important part of the regulation, economic evaluation can be used for many other things as well, not just for NICE specifically and for the recommendation if we're talking about a medical device. So economic evaluation can also be used to explore whether a new technology should be adopted or not. It can also help to identify if there's a gap in the market, establish whether the current technology should be stopped if it turns out not to be cost effective, or if, depending on the stage of the development of the medical device, if development should continue or should be stopped. And that's based on an indication of the maximum price that the NHS may be willing to pay for this new technology, considering its cost effectiveness. So how do we do an economic evaluation, and when do we do it? So an economic evaluation can be done in 3 different stages. The main ones is a trial-based economic evaluation, where we have a control trial, a randomized control trial. We get information from the group of patients, and we do a simple estimation. Well, not as simple, but we can estimate if the data from the collected data from the new technology, and compare it against the standard care, and determine the cost per quality, the incremental cost effectiveness ratio. We can also do a model-based economic evaluation. This means that this is not based on a trial, but is based on what's published in the literature. It could be a collection of different studies that are already showing the effectiveness of an intervention and its costs. So we can create a model, a long-term cost effectiveness evaluation that we call it, to determine if the new intervention would be cost effective against the standard of care. And we can also do early economic evaluations, which means we do this evaluation at early stages when there's little information about the device, because it's under development and there's not a lot of, there haven't been a trial or it hasn't been tested. So when can we do it? As I said, we can do very early stages, like when it's an idea, when it's just starting to be constructed, etc., tested, etc. So we can do an early economic evaluation to estimate the potential cost effectiveness of the device. Or it could be at a later stage when there's much more data on the intervention. It could be, as I said, a trial-based economic evaluation, or based on what's already published. Okay, so what's needed to do an economic evaluation? So the first thing would be to determine where the technology is in terms of its development phase. So it could be an idea under development. You have already a prototype, or a technology that's already developed and you already have data for it. A key thing is to identify what could be the main benefits of the technology versus standard practice. Benefits to the patients, cost saving is a very important thing for medtech. And what's the data that's available? Is there any clinical evidence already? You're planning to do a feasibility, a proof of concept study? There's nothing. Do we need some experts' opinion on what they believe it can happen, etc.? So that's important to try to understand and to frame an economic evaluation for a medical device or any new technology out there. So what's needed? Well, we need some sort of data, some sort of information. That depends also a lot on on the stage of the product. Ideally, the best economic evaluation and the best populated, and will provide the most robust results could be from information from clinical trials, but it's possible also to use data from a feasibility or a proof of concept study. We can do an extensive literature review on the treatment of the pathways to use what is already reported in terms of effectiveness and the use of resources. And if there's not much information, or even if there's information, but there are gaps somewhere in the economic evaluation, we can use experts' opinion to determine some parameters and do some sensitivity analysis, or what we call sensitivity analysis, to test those assumptions and see the impact those assumptions have on the cost effectiveness of the device. Okay, so when there's no data available, so when it's at a development phase, we can estimate a maximum reimbursable price, as I mentioned, for the medical device, for the new intervention, the diagnostic test, or whatever is being analyzed. So I think this is a powerful tool, because based on what the NHS on this threshold at £20,000 per quality gain, we can estimate what's the maximum reimbursable price that the NHS will be willing to pay to adopt or to use this technology, and while maintaining this to be cost effective. This opens some sort of a lot of possibilities, because we can play with the effectiveness of the intervention or the medical device, etc. We can issue recommendations. Well, if your effectiveness is this, or if it saves you so much cost for the NHS, your maximum price can go up to a certain point, and that will remain, the intervention will remain cost effective at that point. So we can create a scenario or threshold analysis to investigate the required level of effectiveness that will require to be a cost saving and cost effective for the NHS. What we don't do is we don't estimate any break-even points or financial projection of business plans or market access. We just focus on the economic evaluation of the interventions or medical devices. Okay, so just to finish, I'm just going to talk a little bit very quickly about an exercise that we did in the academic unit of health economics for a new retraction device for laparoscopic surgery. So this was an innovative retraction device which inserted in the abdominal cavity, it expanded, and it helped the surgeon increase the field of view. So that was the main objective of this device. It was on the development phase, so there was not a lot of information or clinical information about it. So the idea was to estimate the potential cost effectiveness of this new medical device, and given that, a maximum price for the NHS, and if given all those results, could it be useful to carry on developing it. So this graph is one of the end results of the analysis. All of these clouds represent all of our points of uncertainty. Since there's not a lot of information around it, it was based on medical opinion, expert opinion, similar devices in the market, and we were able to estimate the cost effectiveness of the device based on different price ranges. As you can see, the more expensive the medical device is, the higher up it is. This red line represents the £20,000 per quality gain. Anything below this line indicates that the intervention is cost effective. Another important thing is anything below this line that I'm signaling here represents that it's not only cost effective but cost saving, which is an important consideration for medtech technologies. So in this case, a price around £70 per quality, £70 for the medical device, for this disposable medical retraction device, it will indicate that this is cost effective, a good value for money. So we can do these estimations for a medical device. So lastly, I just want to mention what where I work on an academic unit of health economics. So we have a large portfolio of different medical technologies, medical devices, clinical trials, etc. We do mainly economic evaluation using different tools. We have, as I said, we work with other universities. We work with the NHS. We have NIHR projects funded along our clinical trials unit in the university as well. And we have a very large area on test evaluations and medical devices. So obviously, if you are interested in something or have doubts about it, I'm happy to engage in further discussions if it's needed. So yeah, this was a very quick introduction of what's economic evaluation, what's needed, but I hope it gives you like an idea of what's needed and what the NHS requires. That's all. If you have any questions, just if there's any discussion points, I'm happy to discuss this further. So thank you
very much, Armando. This is a very heavy topic. And as I mentioned, in the past experience we've had with some Israeli companies who are approaching us who would like to start working with the NHS, they had the health economics, which was based on the American model. And as you showed to everyone here, the UK model is a bit different and a few modifications have to be made. Again, I think this is a very important topic for any Israeli healthcare company who is wishing or considering working in the UK. We will have a session of Q&A at the end of all the other sessions. However, should one of the participants have an urgent question or direct question to ask Armando, you are free to do so through the Q&A or the chat. So after Armando gave us the foundations to the health economics, I would like to dive into the procurement processes. For this, I'm very happy and honored to introduce Chris Slater, who is Director of Commercial and Procurement at the Leeds Teaching Hospital NHS Trust, who will be able to give us an overview of the UK procurement and the NHS supply chain framework agreement and procurement tips for Israeli companies and companies in general. So Chris, the floor is yours.
Okay, well, thank you very much, and good morning to everybody, and thank you for inviting me along this morning. I'm going to obviously go through the structures for procurement in the NHS. Now, what I would suggest that it is a fairly complex subject, as you'll come to see. But as we've already said, I think if there are any questions that appertain from this, I'm more than happy to, at a later date, to sort of expand on what I'm talking about. So I'll endeavour just to share my screen. Hopefully you can.
Yeah, we can see it, Chris.
You can see that. Perfect. Excellent. Thank you. So as just said there, I'm the Director for Commercial and Procurement at Leeds Teaching Hospitals, which is obviously in the NHS family. We're one of the largest trusts in the English NHS. We have about 2,000 beds over 7 hospitals and provide quite a number of specialist services, one being to the northern region of England, the oncology and cancer services. I guess just to give you an overview of sort of our objectives at an operational level, it's certainly about, as a procurement director, my role is to ensure that we deliver the best technical and innovation solutions that provide the best patient outcomes for the patients that we serve. But I've also got to have that eye on the costs, and I've also got to ensure that I'm providing the best value to the UK taxpayers. Interesting enough, and I think it's fair to say, one of the things that we're not here as an NHS organisation to make profit. We have to cover our costs, and we need to sort of get to a break-even situation, but we're not a profitable organisation, if that makes sense. and if you just go back to Linda's slides in terms of the 4 tiers of the NHS, so we've got the Department of Health who collect the taxes. We're at that bottom tier there, the providers. We sit in there as the providers to the NHS of those services. And I think, as I said earlier, that the overall direction of travel now is to work more of an integrated system in the region. So looking at working with commissioners who effectively take the money from the Department of Health and then pay for the services that we provide. What we're looking for by integrating more closely, that sometimes the transfer of money got in the way of introduction of technologies and so forth. So we're now trying to, as an integrated healthcare system, work more closely with our providers. So I'll try and move to the next slide. Is that moving?
Not yet.
Not yet. Perfect. Let's have a look. There we go. Hopefully that's moved the slide on.
Yes, it is.
Perfect. So again, I think Linda's covered some of these figures already, but just to reiterate, the NHS spends around £27 billion every year on goods and services. So around about, as a trust like ours, 35 to 40% of all the income goes on non-pay. So that's quite a high percentage that we're spending on goods and services to run the healthcare systems. The rest of it, the majority of that, is then paying for staff and so forth. As we've already said, we account for 80% of all healthcare spend in the UK, and it's free for the citizens. So it's the cost model effectively recovered through the taxation of the UK taxpayers, not by the actual users of the system. A very large organisation we've already talked about, and indeed I think we say at the moment 1.5 million employees, so the 5th largest employer in the world at the moment. And we have notwithstanding COVID, we've obviously got a significant patient base, and at the moment post-COVID, of course, one of our priorities is meeting with the backlog of patients that we have on our books at the moment, and getting the patients' treatment to them as soon as possible. And as you can see there, a significant amount of GDP to run the healthcare system. The figures here, by the way, are pre-COVID, so we've not refreshed them sort of post-COVID. So again, notwithstanding the slide that Linda showed a little earlier on, and the complexity, but if I go down into the sort of the provider field, if you like, 135 acute trust providers providing healthcare, if you like, to the patients, and we are one of those. Leeds Teaching Hospitals is one of those 135 acute providers. We've then got mental health trusts, community providers, ambulance trusts, and then the GPs. And then obviously we are supported by the independent sector, that we actually commission certain services from the independent sector, given that our capacity and in some certain circumstances our capabilities. So we do actually commission healthcare services from the independent sector. So I think from a procurement point of view, the first thing to say is that all of those providers, be it mental health, acute providers, community providers, all in their own capacity as providers are undertaking procurement activity, and are making procurement decisions on a daily basis. So there is no direct dictate from the Department of Health all the way through to providers as what they should and shouldn't be procuring, if that makes sense. That decision is very much left with us. However, as we've already heard about the regulatory bodies and the organisations that provide evidence to the NHS, we take that advice, and that helps shape those decisions that we make in terms of what we should buy, where we should buy for those best outcomes for our patients. So within, I'll talk about the English NHS, certainly at the moment, there are 4 principal routes, if you call that, to market for the NHS to procure those goods and services. And the other thing I would say is that procurement in the NHS has had a significant amount of scrutiny, and as a result of that, what I'm going to talk about are some of the sort of later developments in procurement as we've matured as an organisation. Some of the collaboration is now coming through to ensure that we standardise wherever possible, but providing that those best outcomes for the patients. So, as a trust, as I mentioned earlier, we're quite at liberty to enter into contracts with suppliers to provide those goods and services to our clinicians. And part of our role as procurement is to work with clinicians and the technology providers to understand the values that provides to the patient outcomes, the economic value, and you know, I think we've already talked about a little bit earlier on. One of our major, whilst we run a hospital, one of our major considerations is actually minimising hospital stays. If we can keep our patients out of hospital, or certainly shorter stays, that all factors into our decision making of what we should be buying. We do have internal, external regulations. So we have our own, if you like, standing financial instructions as an organisation, being accountable to the taxpayers. We have to ensure that we seek approvals from our own internal governance for contracts that we award. And also, you've got to bear in mind that we are under law still part of the EU, the European regulations, procurement regulations. That will be revised in due course since we've exited the EU. But nonetheless, I think the basic principles that we will adopt going forward will be those of the original EU intentions, and that is of openness and transparency. So as a public body, you know, providing that value to the taxpayers, we need to ensure that we openly advertise opportunities, that opportunities are responded to in an open and transparent way, and every piece of business that we offer is you know, as I say, transparent and that no favoritism, if that makes sense, is given to any one provider. I think it's fair to say we are deemed and seem to be a very, very fair and transparent organisation in the NHS. Again, one of the issues is just because you're selling to one organisation in the NHS, don't believe that is going to be taken up by the wider NHS en masse. Thus, I suppose it's quite an intensive process of selling direct to the NHS as a direct procurement customer. I suppose that then brings me on to NHS supply chain. So, as I mentioned earlier, NHS supply chain since 2016 has seen quite a significant change in the way that we should be procuring goods and services into the NHS. And again, I think it's a positive step for providers, rather than having to go to the 135 acute trusts trying to set up contracts and sell. What we've created in the NHS effectively, or within the supply chain, are the category towers. So I'll come on to the description of what they do, but basically they are category specialists that go out to the market and contract directly with the market to allow the NHS to buy through those contracts. So from our point of view, what we would see as a customer, if you like, would be the category tower going out to the supplier, agreeing the commercials around that, and then the towers, through the top functions you see there, the management function, the Supply Chain Coordination Limited, they would then provide us with a catalogue of products that we can then effectively call off and buy through. Some of that, those products are then either fulfilled direct by the supplier, or in some instances, they can be provided through NHS supply chain through the central warehousing. But it does depend on the product, on the volume, and so forth. But currently, about £6 billion of the 27 billion goes through supply chain. The 2016 review suggests that we should be looking at up to 80% of that demand should be able to come through those supply chain routes. Clearly, that's been delayed in time frame because of the pandemic, but nevertheless, that's an objective going forward of NHS supply chain to corner more of the commercial market, the contracting market, through those category towers. So as I said earlier, I think it's a good sort of step forward for suppliers wanting to gain access to the NHS. The buy decision is still made by the end organisation, whether those goods and services are what that organisation means. But what it does mean is you haven't got 135 organisations coming to you with tenders, contracts, and so forth. This is the composition of the towers. I'll not go into the detail. Obviously, we'll share the slides later. But the companies on the left providing the tower services, some of those, or the majority of those, are actually private sector organisations providing those services, if you like, to the NHS. And on the right, a brief description of what those towers cover and provide. So if your categories fall within there, and again, what I can do at a further date is provide you the more detailed contact information of those towers and who you should really be talking to make contact. So that's one element. I talked again earlier about collaboration between the sort of healthcare sectors, and we can reach out to other institutions, if you like, where we can work with partners to negotiate contracts. So rather than us as individuals going out to the market, looking in regions, so the ones on the left, NHS-owned collaborative partnerships, tend to be regionally based. So I'm, as part of Leeds Teaching Hospitals, we're part of the North of England Commercial Procurement Collaborative, and they go out on behalf of a wider number of trusts, perhaps for some of those services that the towers don't cover, and put collaborative contracts and frameworks in place that then allow us as users to access, so pre-agreed commercials, pre-agreed prices, and effectively fast-tracking some of those products and services that we would want. A traditional procurement for us, over £118,000, as I've mentioned previously, would traditionally take up to 6 months. But if that work has already been done through the collaborative partnerships, we can pretty much go to market within a matter of weeks rather than months. I've put in there additional collaborative partnerships, NHS Shared Services and Health Trust Europe. Again, those are two, if you like, independent collaborative partnerships that we can access. And again, it's just a matter of ensuring that as a system, we're not duplicating what each one of us are doing. So shared services, for instance, will not generally look at services that the NHS collaboratives will do. And then moving to the right, the emerging collaboration between trusts. I said earlier, we're looking at the local health economies. So again, it's about getting those providers working more collaboratively, mental health, social care, and acute providers working together to understand the patient pathway, because some of those patients in previous years will have been treated by these organisations. It's the same patient, but they're having to go to different organisations for their healthcare. And what we're trying to do now is work more collaboratively as healthcare providers to provide the services that our patients need. So it may well be that we start making what we call integrated care systems, ICS decisions, but utilizing some of the tools I've talked about through utilizing contracts, through the collaborative partnerships, and through some of the towers. So you'll start to hear the language about integrated care systems within the UK, but it's still the NHS. But I think, again, it's positivity of us working more closely together in terms of getting the right outcomes for the patient. And again, I'll not labour the point, but collaborative procurement agreements in terms of the benefits, the pros and cons to you as suppliers and to us as providers, speed to market, lack of duplication, reduction in costs. And then just to add a little bit more detail, one of the providers is the Crown Commercial Services, the CCS. So that is a department of our, if you like, arm's length government, providing a cross-governmental service. So it tends to be the generic, probably the non-health related services that the NHS would procure. We would look to put those through a CCS framework if possible. So for instance, staffing or estates and facilities type products would probably come through a CCS channel. So other considerations, I think, as I say, we've already talked about some of the previous speakers about the regulatory authorities, and we would look to these authorities and expertise for advice as to the efficacy of the products, the affordability of the products, and we would be guided by the advice the authorities would give us as to whether those products are suitable for use in our healthcare settings. The only thing I would say is that the end user, if you like, is this final decision maker, the payee come the decision maker. So we would refer to all of these organisations for that absolute critical advice, but the buy decision still rests with the organisation that I'm talking about, the trust or the ICS as we move forward. I think one of the next speakers hopefully is from the Academic Health Science Network, so I'll not go into too much detail there. But again, the introduction of technology through the AHSN is a vital part, that there are eyes and ears on technology and technology providers and are able to bring some of those technologies to us to evaluate, and vice versa. I think our strength by working with the Academic Health Science Network is we can bring clinicians as well, because it's only that there needs to be real life clinicians and real life organisations using those products and clinicians willing to trial them, if that makes sense. So that the Academic Health Science Network is the bridge for us to bring those technologies effectively into the real world of healthcare. A point of order, I suppose, just to say that as you've already heard, the NHS is sort of fragmented into those four nations, home nations of Scotland, Wales, Northern Ireland. So there are some subtle differences. And again, what I've been talking about today is really about the English NHS. So there's a few subtle differences around how some of the home counties work within the NHS framework. And again, I would say just a couple of as a provider of services and more importantly goods, a couple of golden rules that we always say to our suppliers at the end of the day. You know, it's a large, complex organisation, is the NHS. And you've got a lot of willing participants in terms of wanting to look at technologies and bringing innovation into the NHS. But again, at the end of the day, I'm sure as a provider, you want to get paid for the goods and services providing. We have a very, very strict policy in the NHS of no purchase order, no pay. So what I would advise is that if ever you get the opportunity to provide into the NHS, make sure you've got a legitimate purchase order, and then everything effectively flows from that. We have a lot of experience of organisations coming in, working with clinicians directly, not getting the right contract or, more important, purchase order in place, and then we're left with a situation where unfortunately the organisation is not able to pay the supplier, and that's not good for us from a reputational point of view, and not good for you as a supplier. And again, linked to that, I suppose, we just need to ensure that we don't have products coming in through unauthorized channels. It's the hospitals that we work within are open to the public. They are public buildings, and very much open environments, so anybody can have access. But what that also means is that we have delivery drivers making deliveries to departments. We have often representatives making deliveries to departments, and we just need to ensure we've got a very structured approach to procurement, again in everybody's interest, from a health and safety point of view, a legal regulatory point of view, and from a business point of view, ensuring that the supplier gets paid. And then finally, the final part, and I say this to all our suppliers, and it's really our sort of safety net, and we saw this throughout the pandemic. A lot of product came to market very, very quickly, and quite frankly, it wasn't fit for purpose. So the first thing that any of my buyers or contracting team will ask and seek is CE mark certification. And therefore ensure that by the time we get to a sale, the product is CE marked. Now that may change in due course, again, post-Brexit, post-regulatory demise, if you like. We may start to look at British standards coming in again, but for the time being, we're very much working under the EU certification and mark and so forth. So I realised that, again, unlike previous colleagues, is a very, very swift run through what is potentially quite a complex organisation, a complex area. But again, what I would say is we're here to help. We are, if I go back to my opening statement about looking for the best technical innovations for our patients in the NHS at the most affordable price to the UK taxpayers. So, we are open for business. We do want to take those best in breed technologies and introduce those to our technology. So I think, from an objective point of view, we are very much aligned. So thank you very much.
Thank you very much, Chris. Very useful and important presentation. And I must say the last topic with the CE mark is awfully important. From our case, some Israeli companies thought that after Brexit, the UK will follow different guidelines. And still, I must admit, the UK is following the European guidelines. And just mentioning to our guests today that in the end of December, we've had a webinar together with the Israel Export Institute and MHRA, which is the UK regulatory body which regulates medicine and healthcare products, talking specifically about regulation in the post-COVID era. So if any of you are interested in getting the link to these presentations and the webinar, we'd be very happy to share. Moving on to the last part of our webinar today. So once we discussed about the framework of the NHS and then healthcare economy and how procurement works, I would like to put forward a topic of the available support in the UK for companies, local and foreign companies alike. And for that, I would like to invite three speakers. Colin Callow, Head of the International Programs at the Innovation Agency AHSN, which also Chris mentioned. I would like to invite Elaine Evans, a life science specialist at DIT Northern Powerhouse, and also Jennifer Robson, Health and Life Science Sector Manager at West Yorkshire Combined Authority. Everyone is here, and I will do the I will manage the presentation. So you will be able to guide me to go forward or backward. So maybe we'll start with you, Colin. If you can give us a short introduction of yourself, the HSN, and I will share your slide.
Thank you, Ofer. Good afternoon, everybody. Welcome from Manchester here in the United Kingdom. My name is Colin Callow. I'm Head of International Programs at the Innovation Agency. So the Innovation Agency is an academic health science network, which is a little bit misleading because we're not academic, but we're not scientists, but we are part of a network of 15 organizations in England that you could describe as the innovation arm of the NHS. And our role really, we've been around since about 2013, is to accelerate the adoption and spread of innovations, technologies, products and services that have the opportunity to transform healthcare here in the United Kingdom. So in the next few minutes, I think I've got about 5 minutes, so it's a bit of a whistle-stop tour about our comprehensive business support offer that we offer to international companies. It will be quick, so if you don't catch what I'm saying, on the right-hand side of the holding slide that Offer's put up, there is a digital brochure that we've developed which summarizes, gives you much more detail about what's on offer to international companies in terms of support. It's probably worth saying that we are funded by and commissioned by the Office for Life Sciences, government body to grow the life science sector here in the UK, and also the National Commissioner of Healthcare Services in England, NHS England, to provide this kind of support. So in essence, we're all about connecting international companies with both regional and national networks. And Chris touched on the fact that academic health science networks are the innovation arm of the NHS in England, but for the perspective of our international work, we have a reach right across the United Kingdom, and we connect those businesses with academic organisations, local authorities, the third sector, patient representative organisation, and it's all about supporting partnership and collaboration. So what does our comprehensive business support offer look like? It's broken down into 11 key areas, really. That starts with system engagement. So as the innovation arm of the NHS, we help international companies to navigate the complex landscape. And we helped international companies to connect with the right key opinion leaders, the right decision makers, the right policy makers. We also provide support around market analysis. So we're very privileged to have access to unified NHS patient data sets. And more importantly, the analysis expertise to help international companies map current care pathways here in the UK and really to understand resource utilization. So not only can you get a baseline, but it also helps you to speak the same language as decision makers here in the UK. We support international companies to refine and validate their value proposition. It's really important that you use UK data. And as I said, that it speaks the same language as your target NHS decision makers. We also offer support to engage with users, with patients and their advocacy groups, providing those crucial insights at all stages of product development. And that's all about mitigating the risk of market failure. I won't go into great detail about procurement because you've heard a lot about that already from Chris this morning. But yeah, providing that access to that specialist understanding of NHS procurement selection processes. So you get a deep insight into what commissioning authorities are looking for. And of course, making sure that you're aware of those tender and contract opportunities as they arise. A big part of our work with international companies is supporting evaluation support. So that's about planning, measuring and reporting impact, study protocol design, what data should be collected and how, and then supporting the dissemination of those results, a business case development here in the NHS. And at the moment, we've got around a portfolio of around 25 international companies where we're supporting innovation adoption projects across the United Kingdom. Access to specialist advice around helping you to develop your regulatory strategy for the UK, whether that's for a UK CA mark, engagement with notified body, or identifying that UK responsible person. You've already heard from Amando around support around health economic analysis. I think it's really important that you get the right access to advice and support around economic evaluation. And that could be budget impact modeling, could be cost consequence analysis, etc. It's also important to understand the reimbursement pathways and commissioning incentives at both the local and national level. And we provide advice to that expertise too. And then finally, we can provide access to our network of UK investors who really have a track record of investing in life science care technologies, products and services. So I'm sorry that was very quick, but it's a bit of a whistle-stop tour of what kind of support is on offer here in the UK. A big thank you to those companies that have reached out already. And we look forward in the coming weeks to exploring how we can support you. You can contact me directly by email, or if you want to download our international brochure on the link that you can see on the holding slide that Offer's put up there, there's also a contact us button that you can press on to reach out to us directly. Thanks very much for listening.
Thank you very much, Colin. I must say that from our point of view, the Israel Economic Mission to the UK, the AHSN in general, is the network to work with when it comes to guiding Israeli companies into the NHS and providing some sort of a link between the NHS and the technologies themselves in case of guidance and support. So I'd like to thank you very much, Colin, for your specific support and the general support we receive from the AHSN. I would like to move forward and invite Elaine to give us her a point of view from the DIT, or Department of International Trade, when it comes to support for companies.
Thank you very much for inviting me off there. I'm Elaine Evans. I'm part of a dedicated inward investment team covering the north of England that's also known as the Northern Powerhouse. I'm the sector specialist for life sciences, and my job is to understand the strengths of all the different life sciences subsectors across the north so that I can make personal and relevant introductions for companies that I'm supporting. So that's kind of who I am. Could I have the next slide, please, Ofer? So I'm just going to give you really a brief summary of the particular strengths of life sciences in the north and an overview of some of the incentives for setting up companies in the UK. So if we move to the next slide, this is the Northern Powerhouse in numbers. So it has a population of around 16 million people, and that's out of the UK's population of 67 million. And over the last decade, the life sciences sector has been growing in the north and has actually employed more people over that time than London and the southeast. And there's a really rich ecosystem of over 1,300 life sciences companies and organisations. The biggest subsector by turnover is the pharmaceutical sector, the biopharma sector, although in absolute numbers there are more medtech companies. There are more than twice as many medtech companies. There isn't time for me today to tell to you about all the different specialist clusters across the north of England, so I'm just going to focus on one good reason that you should look at the north. So if we go to the next slide, please. The cost of living here is much lower than in London and the southeast. And this slide shows some recent survey data for it's the average cost paid by people buying their first property and the median annual earnings for full-time employees. And you'll get a copy of these slides, and I'll encourage you to look closely at the figures. But so whether you decide to come to the north or not, there's good reasons for looking at the UK. So if we go to the next slide, I'll cover some of those. So the UK has the lowest corporation tax in the G20 countries, and it will stay at 19% until 2023. You could look also at from the science perspective. The UK is world renowned for its education system and its innovative outlook. In addition to this, the UK has a business-friendly visa system and a new points-based system to make it easier for UK employers to attract talent from overseas. I'll go into some more detail on some of the tax incentives. So if you go to the next slide, please, Ofer. The R&D tax scheme is generous and internationally competitive. So research and development relief, it allows companies that carry out qualifying R&D to claim an extra corporation tax deduction for certain expenditure. And in practice, this means that companies can claim cash back against the money they spend on R&D. Under the patent box scheme, corporation tax on profits that are earned from patented inventions and certain other IP is set at a reduced tax rate of just 10%. And the scheme's, it's designed to encourage companies to keep and to commercialise intellectual property in the UK and to locate jobs here. Then the Seed Enterprise Investment Scheme and the Enterprise Investment Scheme are both designed to help high-risk startup companies to raise money. So when your company's in one of those schemes, investors who buy new shares in your company benefit from tax relief. Sorry, they benefit from tax relief, which means that your company is attractive as an investment proposition. So next slide, please. So the new super deduction arrangement encourages firms to invest in plant and machinery assets that will help the company grow. So until the end of March 2023, companies investing in qualifying new assets will benefit from a 130% first-year capital allowance. And as the tax deduction is made upfront, it accelerates depreciation. And so this scheme means that it will cut a company's tax bill by up to 25 pence for every £1 spent in the first year of investment. And investing companies will also benefit from a 50% first-year allowance for qualifying special rate assets. So next slide, please. And my colleague Linda McGee already mentioned the UK's new life sciences vision. This sets out, it's a 10-year strategy to address some of the biggest healthcare problems of our generation. And alongside this vision, there's a new life sciences investment programme, which will make £1 billion available for investing in promising UK-based life sciences companies. So another good reason to set up your company in the UK. So just to go to the last slide, please, Ofer. So the Department for International Trade can offer advice on these various schemes. So do get in touch with me. I'm not the expert on the tax schemes. I'm the life sciences specialist, but if you come through me, I can direct you, and I can certainly help link you up with relevant contacts across the north. So thank you very much. And so back to Ofer.
Thank you, Elaine. I would like just to complete the picture to invite Jennifer Robson to provide us some more details about support given in the health corridor and by your organization. So Jennifer, maybe we'll start with a short introduction of yourself, followed by the support schemes.
Hi everybody, I thought I'd just speak to you and tell you the story of how it actually works in practice, rather than bombard you with another slide deck. Because it's really my role as the Health and Life Sciences Sector Manager for the Leeds City region to connect all these different pieces together and be your first point of call when you land, or when you're approaching the journey to landing it in the UK. So we work from you right from the point that you're considering the UK, all the way through to successfully establishing a business, ideally within our region, but perhaps the wider Northern Powerhouse or the wider UK. One of the initiatives that I've been working on over the last 12 months is the most relevant to you as Israeli companies looking at the UK for the first time. So that's something that we were originally calling the Israeli Initiative, because we're not marketing people, we're trade and investment people, and that's what we focus on. So the Israeli Initiative is about connecting a recognised group of innovative Israeli companies with the unmet needs within the NHS. And so what we did is we took out a mission of the Leeds Teaching Hospital Trust, the Academic Health Science Network, the National Health Science Alliance, DIT, to Israel's leading biohealth conference in 2019 prior to the pandemic. At that conference, the UK counterparts were blown away by the level of innovation in Israeli health tech companies and decided that at that point we need to be integrating these Israeli technologies into the NHS faster and find a more efficient pathway. So what they did is look at a large group, and it was almost like a Dragon's Den type process the Israelis pitched. It was whittled down, and ever since we've been working with about 12 companies to help them to access the UK via the Leeds City region. And in this process, which we're calling the Israeli Initiative, we've been working with a wider group of Israeli companies to look at what the UK and Leeds City region can specifically offer. And that has involved so far landing one Israeli company, a company called Bettelin Therapeutics. Bettelin, some of you might be familiar with, but they have a therapeutic device that can be applied into a patient's arm and can help to regulate insulin production and could potentially solve type 1 diabetes. It's currently going through clinical trials in the UK, and they've established a UK base in order to accelerate their technology into the NHS, which will involve working with some of the partners that have already spoken. So no doubt they're in touch with Armando. They'll certainly need to look at the procurement process, and they have been working actively with our Academic Health Science Network, which doesn't have a nice name like the Manchester one, but it's just called the Yorkshire and Humber Academic Health Science Network. But equally good, and has been working very closely with Bettelin to help them to accelerate their products into the NHS and get ready for that and go through the regulatory approval. We're also working with 3 other companies that are very close to landing. Some of them looking at data and AI, which is one of the core strengths of the Leeds City region. So we have 3 recognised core strengths. Data and analytics for medical technologies, which has been utilised, as I said, by the Israeli companies involved in the initiative. Wound care and regenerative tissue, which we did a high potential opportunity on, which is the Department of International Trade's phrase for identifying a specific location within the UK that has specific excellence in an area. So we're currently doing one on data and AI, but our first one is wound care and regenerative tissue, of which some of the Israeli companies have also contributed to, and I work with them to do that. The final piece, which is the one that's probably going to become of increased interest to Israeli companies, and has certainly been the topic of conversation for the last few companies that I've been speaking to, has been diagnostics and preventative medicine, precision personalised medicine. Some of the technologies that already exist and are operational in Israel are of particular interest in that scope in terms of helping to diagnose people faster and treat their personal condition based on their personal genomics, rather than a standard solution to fit all, which doesn't always fit all. So we've had some really interesting conversations with companies about new solutions that are much more targeted, or that can help prevent some of the more distressing patient outcomes at a later stage by intervening sooner. So to get involved in the Israeli initiative, I would say certainly express an interest initially with myself. I can then triage that to the Leeds Teaching Hospital Trust Innovation Team and the Yorkshire and Humber Academic Health Science Network. We also work really closely with Elaine, so if it's not quite suitable for Yorkshire and Humber, Elaine then triages it through to our partners like Chris in Manchester, Colin in Manchester, or other colleagues in the Northeast or the Humber region. And we can look about where it's suitable to land within the Northern Powerhouse. If for some reason it's not suitable in the Northern Powerhouse, we work with our wider DIT team to look at other places in the country. But usually we can find a solution fairly quickly. Yeah, I'm going to stop there and take questions instead.
Thank you very much, Jennifer. I would like just to acknowledge that the relationship that we have with the Israel Economic Mission, with the Leeds Teaching Hospital NHS Trust, and the Yorkshire and Humber area in general, including the AHSN, has been very close. I think you mentioned, Jennifer, you came to Israel. It was for Biomed in 2019. Yes. Seems like a generation ago with the past 18 months that we've had. But I just want to mention that this relationship is long-lasting, and as Jennifer mentioned already, a few Israeli companies are in touch and are starting to do clinical trials and more advanced work in the NHS. And that leads us to the Q&A session. We are just 5 minutes behind time, but I have a few questions that I just have to ask. So if you all permit me, I will just steal 7 minutes from your time. The first question I would like to ask is for Armando and also for Chris. Well, we haven't talked about the pandemic, but it's always behind the scenes. My question to Armando, has the healthcare economy changed or developed when it came to tackling the pandemic in the NHS, or has it had any development on the processes of healthcare economy?
I think it has been more focused now as well on the pressure that the NHS is experimenting based on this. This has been, I mean, it's always been an issue during the winter months in some hospitals based on the influenza yearly pandemic, but I think that was highlighted with the COVID one. So I think there's a bit more of a notice of the need to do analysis based on the capacity of the system, how new interventions, medical devices, etc., can help alleviate the waiting times that the patients might be experimenting. So I think that's a good, if the medical devices that you're working on, the new technology, doesn't have a clear impact on the quality of life of the patient along the lifetime, but it does have an impact on the waiting times and overall functioning of the system. I think it's a good time to also consider that as a potential way into the NHS. I think that has been highlighted by the pandemic. Yeah.
Thank you, Armando. And maybe Chris, I will modify the question for you. You mentioned the backlog of the non-COVID care in the NHS, and also Armando mentioned it in his response. Has the situation of this backlog critically affected the channels, the procurement channels program or the processes?
I'll probably answer the first question, the question you posed previously as well, if that's okay, because certainly from my point of view, there's definitely a change in emphasis from a procurement perspective. First and foremost, relationships, supplier relationships are very much in our mind now. Where we've got good, strong supplier relationships, generally during the pandemic, we got the goods and the products that we wanted. So the need to understand the supplier and have good, strong links with the supplier. The second thing is resilience, to ensure that we've got supply chain resilience, because we got caught in the early days with very little resilience in our supply chains. And therefore our whole strategy around resilience and indeed how we buy and hold and store goods has changed. So as a result of the pandemic, we've now got a warehouse that will house 1,200 pallets in Leeds teaching hospitals. We never had a warehouse before, so that changes the dynamics slightly. In terms of the backlog, again, I think it was fair to say that during the pandemic, our emphasis clearly moved towards the likes of PPE, scheduling PPE, and actually in terms of the volume and value of sales, and indeed our sort of own work plan around contracts and so forth, the value of traditional sales fell away because we weren't doing those electives at the moment. At that point in time, and suddenly our own work plan of going to market, etc., we sort of extended the contracts we had. So we're now sort of kicking off again, almost with a new work plan to go out to the market for replacement of those contracts with those suppliers. So it's a good opportunity. But what I would say is by no means are we back to business as usual. You know, we are still treating patients with COVID. It tends to ebb and flow. Fortunately, the hospital numbers are still relatively low at the moment. But certainly, I think we are. I would say we're a good 8 months behind in terms of the normal work plan. We're just re-establishing those relationships. But again, going back to those relationships, it's key that we understand the sustainability of the supply chains, and should we have another surge, that we've got reliance. Because I think, again, what will be different in the future from a hospital perspective is where we cancelled all electives very early on in the pandemic. I don't see that happening again. I think we'll run our COVID services alongside our effectively elective services as we go forward. So that will put significant amounts of strain on both the supply chain and indeed the staffing.
Thank you very much, Chris. That's very comforting. My next question is for Linda, Jennifer, Colin, and Elaine. With your engagement with technology and startups and the NHS altogether, from your point of view, what are the hottest topics at the moment when it comes to the NHS and the healthcare, I would say, here in the UK?
Who do you like to go?
I'll maybe kick off. I don't think I said it in the presentation, but it was there on the slide. I mean, the digitisation and the digital enablement of both products and services is very important. I think Jennifer mentioned, preventative healthcare and precision medicine, diagnostics have obviously come to the fore. And people who never knew what a diagnostic was now know what it is from COVID. So I think everyone's become a mini expert. But I'll stop there, and I think Colin's appeared as well. So I'll let my other colleagues speak too.
Yeah, thanks, Linda. I think two things stand out for me, I suppose. One is AI-enabled digital technologies. Huge investment going into that area at the moment. I think £250 million over 3 years. There's big competition open at the moment. The AI Healthcare Award, which I think is probably giving grants or at least contracts out for about £50 million a couple of times a year at the moment. So, and of course, I suppose the second thing is being aligned to the NHS's pressing need to try and recover its elective activity post-COVID. So anything that can help the NHS build back after COVID. We've still got some real capacity and demand challenges, and some of those AI technologies can play a really pivotal role in that.
I I would add to that, some of the most exciting technologies that I've seen and reviewed with NHS colleagues at the Leeds Teaching Hospital Trust recently have been AI-driven services that can enable one clinician to treat multiple patients simultaneously, particularly technologies that allow fast diagnosis as well. Some of the radiology teams are looking at some exciting technologies that speed up the detection of cancer and through images being collected in a much more comprehensive way and allowing faster access to clinicians in different places around the world being able to diagnose quickly. So there's been some quite innovative solutions accelerated by the pandemic, because whereas before we might have been averse to applying these technologies quickly, some of those restrictions have lifted in the pandemic, and teams have been more open to and receptive to, well, we need to treat a patient at arm's length. How can we do that effectively? Which technologies can allow us to do that? And I think those technologies will remain post-pandemic and continue to improve the service. There's also been really comprehensive work done in our region around care records and utilising those, particularly at the point where primary, secondary and care in the care home type environment outside of the hospital network takes place, and that a lot of companies are feeding into that care funding round that's going on at the moment that Colin just mentioned, solutions that allow data and the discharge of patients from one part of the system to another to not be lost in that discharge process. So there's some quite exciting technologies out there at the moment.
So following on from that, so just again, I would pick up so AI and just to sing the praises of the Leeds City region. So one of the things that they have there is the national, if I get the name right, the National Pathology Imaging Cooperative, which is looking at AI in pathology, and that's likely to be the first area where the NHS actually adopts adopts into the NHS, so the use of AI. But another area I'll throw in where a number of the major hospitals across the north are engaged in collaboration in major consortia is in advanced therapies. So in fact, Betulin is the company from Israel that Jen mentioned earlier, is working both with Leeds NHS Trust Hospital and Newcastle NHS Trust Hospitals. The UK has really been leading globally in looking at how do you commercially adopt advanced therapies, so cell and gene therapy. So that's definitely an area of great interest to us.
Just to quickly, come back to the AI technologies. One that I mentioned that is potentially its effectiveness is not seen as a quality of life gain for the patient, but the speed of diagnosis or the less use of resources of professionals to diagnose a condition can alleviate the waiting times. And I think that's now been an important component that's discussed in health economics, that is the capacity limitations and how new technologies can help on that.
Thank you very much, Armando, and also Elaine, Jennifer, Linda, and Colin for your reference. There is an idea in, I would say, the philosophy of innovation that war is the catalyst for innovation. For example, in World War I, aviation technologies really evolved during the war. So in that case, now we have the ability to fly somewhere if we can. Unfortunately, we've had a very tough 18 months with COVID. However, as we are learning how to live with COVID, still COVID has been a catalyst for digitalization of healthcare systems throughout the world, including Israel and also here in the UK. I am very optimistic that we all will become more digital and the healthcare will become more advanced in introduction of these technologies. Since we are out of time and we are 17 minutes behind schedule, I would like to conclude our webinar today. I would like first and foremost to thank our speakers for taking time off from their busy schedule and joining us today. I would like to thank you for making the time of being with us today. So thank you very much, Linda, Jennifer, Elaine, Colin, Armando, and of course, Chris. And I would like also to thank our guests for joining us today. As mentioned, this session is videoed, so we will be uploaded. And we also be able to share some sort of Google Docs with our guests if they want to communicate with any of the speakers, and we'll be very happy to do the introductions. So I'd like to thank you very much and have a lovely weekend.